Ciao Mario, dear Chairman, it's a pleasure. Let me to thank Fulvio and Walter for the kind invitation, and also for the title. I appreciated the last presentation. My presentation is something probably far, but is a different aspect that is very important in patients with asthma, that is asthma and lung mechanics, that is not very common during conference. So I'm very happy to have the opportunity to discuss this topic. And we know that in patients with asthma, compared to the other obstructive disease that is COPD, evidently, the main problem is the narrowing of the airway. And for this, we know that the critical role is the airway diameter. Since the airway diameter, the radius, the force power of the radius has an inverse correlation with airway resistance. So in patients with asthma, we know that this is the focus of the problem. In general, we know that obstructive pathologies such as COPD have two main problems: the reduction of the arterial coil of the lung and the airway disease. We know that in the field of asthma, the problem is mainly related to the airways, and for this, I don't know if this is something to discuss probably later. I think that is quite impossible to speak about the asthma and COPD overlap, but we can speak easily about the overlap between asthma and emphysema, since emphysema is no part, evidently, of the history of asthma, also in patients with very severe disease. And even if we spoke a lot about inflammation, infection, and microbiome, we know that the impairment of the lung mechanics in asthma is asthma, since the consequence of airway narrowing are wheezing, expiratory flow limitation, gas trapping, and hyperinflation, ventilatory heterogeneity, ventilation perfusion mismatching, and airway hyperresponsiveness. And we know that we define asthma with these features. We know that sometimes inflammation is not evident or is not so important, but to be a patient with asthma, our patients to show to have this at least in some moment of their life, this feature, these mechanical features, this difference compared to the other subject. And even if the disease is limited to the airways without an impairment of the lung parenchyma, we know that the narrowing of the airways is quite complex, as demonstrated by many papers, also from the School of Genova with Manlio and from Professor Pellegrino in Italy. We are considered experts in this field, and the narrowing is something important because the caliber is regulated by surrounding airway smooth muscle force that try to balance the parenchymal tethering, but there are also other factors that can affect the caliber of the airways, including the thickness of the airways due to inflammation, edema, and remodeling, but also mucosal folding. That is the only way that airways has to try to balance the narrowing. The geometric amplification of airway narrowing by the presence of mucus and airway lining fluid. And finally, the elastic property of the airway wall per se. So even if asthma is limited, we can say, to a disease of the airways, the disease of the airways is something quite complex also by the mechanical point of view. And we know that airway hyperresponsiveness is something crucial for asthma. It's probably the main mechanical property that is able to differentiate a patient with compared to a patient without asthma. And sure, the contractility of smooth muscle is very important, and they have an increased force and increased sensitivity. We don't know if this change of the smooth muscle is per se or is the answer to the inflammatory behavior in asthmatic patient. But then we have also other features that are very important. So the reduced airway parenchymal tethering and the reduced airway wall stiffness, but also geometric features that are very important, including thickness of the airway wall. And last but not least, also the impaired epithelium barrier function. We are discussing now by the new biological therapy, the importance of this aspect for inflammation, but also this is very important by the mechanical point of view because the epithelium barrier tend to protect the wall, the airway wall towards some trigger, some negative trigger. And we know that the airway hyperresponsiveness is something that we tended to measure probably before more than now, because we know that metacolin challenge test is very sensitive but not specific. So in the clinical practice, it's probably more important to rule out asthma compared to confirm the diagnosis. But here, the behavior of different subjects. In normal subject, the shape is on the right. What's happening in case of asthma? In case of asthma, there is a shift of this curve upward and leftward for an increased response and increased sensitivity. And then there is another aspect very important. In normal subject, there is a plateau. So at a certain level, there is no more capacity to reduce the diameter of the airways. And this is not the behavior of all asthmatic patients, even if probably in some more severe asthmatic patient, remodeling can protect the patient to this continuous narrowing of the airways that can be very severe, and probably is the mechanical behavior of patient with life-threatening asthma. So usually in the clinical practice, when we carried out a metacolin challenge test, we do not go on once the 20% reduction of A1 has been obtained, but to understand if there is a plateau or not could be theoretically a way to select to find patients that can have more severe exacerbation, more severe respiratory failure or asthma attack. And so the altered lung mechanics, and that are ventilatory heterogeneity, gas trapping, airway hyperresponsiveness, lung rust recoil, airway resistance, and airflow limitation, are the most important part, and they led to symptoms that include asthma severity, asthma loss of control. That is something we evaluate in the clinical practice every day. And spirometry evidently is crucial for the evaluation of patients with asthma, not only for the diagnosis, but also for the follow-up. But now we know that we have to use more instruments for the evaluation of patients, because different instruments can give us other information. And one of these is oscillometry, that now is quite is largely present, at least in bigger hospital. And we know that oscillometry, together with spirometry, global spirometry, but also nitrogen washout, are very important to find patients with small airway disease. Small airway disease is something crucial in the clinical practice, because we know that patients with these aspect are patients with poor asthma control and asthma severity. Unfortunately, as I said before, we cannot reduce our evaluation to one tool, because we know that we have to find the small airway disease by spirometry, but also by oscillometry, nitrogen washout, global spirometry, because we know that patients with at least one of the feature of small airway disease can have this negative behavior, clinical behavior, that is very important to know in each patient, because can change our approach, can change our treatment, because we know that these patients are more severe patients compared to patients without small airway disease. But the mechanical properties of the lung, of the airways in the field of asthma are very important, mainly when during very severe asthma attack. This is probably, at least in my experience, the most severe patient I met in during my life when I was on shift in the emergency room. This is a case of very severe respiratory acidosis. You can see 6.9 of pH with 130 of PaCO2, so a patient with a near fatal asthma. First of all, we know that the terminology is quite heterogeneous, not only in Italian, I'm sure, but also in English, and we can use different terminology from severe exacerbation, flare up, and this is the approach suggested by Gina. And we know that patients with more severe cases of asthma are patients with an history of near fatal asthma, because probably for this, I mentioned the presence of a plateau during metacolin challenge test. These are patients that are not protected by the excessive narrowing of the airways compared to other patients that even if in case of severe asthma will not become so severe. And we know that the overuse of short-acting beta-2 agonists that mainly risk factors to very severe exacerbation. Only a few words on the medical treatment. Is very easy because short-acting beta-2 agonist inhalatory, hypertrophic bromide inhalatory, oxygen if needed, systemic IV, and magnesium is the only treatment that are able. All the other things that are not included in this list are not useful, such as the use of systemic beta-2 agonists, the use of other approach that sometimes we evaluate, we can see during clinical practice. The treatment, the evidence-based treatment is very easy to remember and include only these drugs. What about the other treatment? And speaking about the mechanical properties of the lung of patient with asthma, it's very interesting to discuss the role of helium and oxygen mixture. That can be useful because this mixture compared to nitrogen oxygen mixture, so air, have a lower density. And so both in normal subject and in patient with small airway disease, asthma, and with the same mechanical properties of the lung and of the airways, is using this mixture, is possible for our patient to increase the flow as demonstrated in this slide. And here the effect of helium during asthma. Unfortunately, helium is able to improve pulmonary function test, but in more severe patients during severe exacerbation, the improvement of pulmonary function test is not probably our main outcome. But unfortunately, it's not able to change the history of this patient. So the hospital admission and risk of intubation is absolutely the same. So we can, using some words of Professor Milicemili, who studied a lot the helium, the use of helium is similar in efficacy with salbutamol. For this, in clinical practice, this approach is not being developed a lot. What about the effect of positive pressure? And we know that positive pressure, CPAP in this case, can have some positive effect in patients of asthma due to the increase of the diameter of the small and medium bronchi. So the increase of pressure can be something positive. If we evaluate the guidelines of non-invasive positive pressure ventilation, so bi-level ventilation, as you can see, the no recommendation made in case of acute asthma exacerbation. And here is the comment, due to the uncertainty about the evidence, and this is the very sad meta-analysis, because a meta-analysis with only one study, no effect on the risk of intubation. And now this is a very recent review. The situation about the evidence of the efficacy of NIV in patients with severe asthma exacerbation are still limited, as you can see. But the use of NIV in selected setting population is increasing, because as you can see now, at least 1 out of 3 patients with very severe asthma attack is managed with NIV. I have to repeat this only in in a very monitored setting. And there are still absolute contraindication to NIV, so decreased alertness, high risk aspiration, or physical restraints due to hesitation of or relative contraindication, such as hemodynamic instability or severe hypercapnia or hypoxemia. And if we decide to use positive pressure ventilation in patients with very severe asthma attack, we have to monitor pulmonary hyperinflation. We have to assess pulmonary hyperinflation. Pulmonary hyperinflation is good or is bad in patients with asthma or in patients with COPD. And by the mechanical point of view, we can say that it's positive. And this is the reason for this automatic reaction by mechanical point of view in case of obstruction, because the pulmonary hyperinflation can increase the elastic recoil of the lung and increase the diameter of the airway. So higher is the volume, higher is the capacity to generate flow. However, we will see dynamic hyperinflation is also a risk factor for a side effect in patients with severe asthma. How to evaluate, how to assess dynamic hyperinflation in patients with asthma? If you use non-invasive ventilation in patient that is spontaneous breathing, unfortunately, we cannot measure in a correct way the pulmonary hyperinflation. We can only assess the flow time curve that all our ventilator now can show us. And the behavior is such as in the red circle. And there is no zero flow before the new inspiration, and this aspect is typical of patient with auto-PEEP. And so in this case, but we will see this is more true in the field of COPD, a very cautious increase of external PEEP can be suggested. We can measure the dynamic hyperinflation only in patient, not only intubated, but deeply sedated, if not paralyzed. And the more simple way to measure is by an expiratory pause. That is something that all ICU ventilator can get. And in this case, we can measure the auto-PEEP. And usually, once we know the level of auto-PEEP, the suggestion is to use more or less 80% of external PEEP compared to the level we measure. But then there are other methods, at least in asthma, that are suggested. This is the lung volume at the end inspiration. That is something different compared to end expiratory lung volume. That is the total volume. So it is the FRC of critical patient, we can say. And this volume is measured by a very long, prolonged apnea, and it depends on the tidal volume and dynamic hyperinflation. And as you can see in my slide, this volume was found to be the most reliable predictor of ventilator-related complication. And another parameter we can use during mechanical ventilation in patients with very severe asthma is the plateau pressure. Plateau pressure is something used in RDS mainly to evaluate the risk of ventilator-induced lung injury. And in the field of RDS, it depends mainly on the compliance of the lung. So the compliance of the lung is very low. The plateau pressure is higher. Usually we use a 30 millimeter of mercury as a cutoff. This is dangerous for the patient. Why to assess the plateau pressure in patients with asthma? That is totally different disease with a normal compliance of the lung. Because the plateau pressure depends not only on the elastic part of the mechanical properties of the lung, but also on the auto-PEEP. So in case of dynamic hyperinflation, also in case also with a non-normal lung with a normal elastic recoil, this plateau pressure is in any case a parameter that can help us to select patient with a good ventilation compared to patient without a good ventilation. What do we have to do during the ventilation of patients with severe asthma? We have to reduce dynamic hyperinflation. So controlled ventilation is suggested with low tidal volume and with very very, very low respiratory rate with an inspiratory-expiratory ratio between 1 to 4 up to 1 to 6 to avoid dynamic hyperinflation. This is the effect of respiratory rate. As you can see, if we are able to reduce the respiratory rate from 18 to 6, we can reduce the auto-PEEP and the plateau pressure. Unfortunately, this leads usually to hypercapnia, and for this, we have to find the balance between the permissive hypercapnia to the protective ventilation of the patient. And the only intriguing part compared to the other disease that is COPD is the use of external PEEP. In patients with COPD, we tend to use a PEEP to balance the auto-PEEP, and usually this is safe. In the case of asthma, since the disease is limited to the airways, sometimes, as you can see, patients are ventilated without PEEP, so-called SEEP. And why? Because we know that we can have the first scenario, so we can increase the external PEEP with a so-called PEEP test. And we can avoid up to 60% of the external PEEP dynamic hyperinflation. That is something we have to avoid. And so we can set the best PEEP. In some cases, we have to avoid the external PEEP because also with the low level of external PEEP, as you can see in the B example, there is an increase of lung volume. So do not use in this specific asthmatic patient external PEEP. We have to work with ZIP. And then there are also patients that, due to the effect on the airways of the positive pressure, and the lung volume can be reduced by the introduction of an external PEEP. So the suggestion is be wise in the use of external PEEP in patients with asthma. Sometimes we have to avoid the introduction of an external PEEP, but we have to monitor, we have to assess lung volume to avoid hyperinflation and to understand if in each specific patient external PEEP can be useful. So this is my last slide. The impairment of mechanic in asthma is asthma because it's absolutely the definition of the disease, and this is the main property of asthmatic patient compared to patient without this disease. And mainly during severe asthma exacerbation, we have to manage ventilation, and by knowing the specific features of our patient, because mechanical ventilation is in this setting sometimes very difficult. And this was my last slide. I have to thank you for your kind attention.